Dear students, today we are going to spend our time with retinoblastoma. There are many ocular tumors that occur in children and adults. In children, the most common ocular malignancy is usually retinoblastomas. And in adult, the most commonly seen ocular malignancy is malignant melanomas or choroidal melanomas. But here you see that I've written like it is the second most common intraocular malignant tumor in the eye, because the first most common intraocular malignant tumor is neuroblastoma. Neuroblastoma, but most of the times is not viable. The children don't live to manifest the disease. Retinoblastoma is the second most common intraocular malignancy, but mostly in our clinical settings, the most commonly seen ocular malignancy which goes to treatment is retinoblastoma. Retinoblastoma is basically a tumor of the primitive retinal cells. The primitive retinal cells develop a malignancy. The primitive retinal cells developing a malignancy is called retinoblastoma. Presentation of retinoblastoma can be bilateral or unilateral. Usually, unilateral cases are sporadic and they occur after 2 years of age. That is, if you draw a family tree, a pedigree chart of this baby, no other family member will be suffering from the disease and the child would have got it sporadically. Similarly, bilateral retinoblastoma babies are most of the times familial. So if you draw a pedigree chart of these babies, there will be family members suffering from this tumor, and most of the times they manifest yearly, like in the first year of life itself, they manifest this. In the genetics, two questions are commonly asked. One question I've already addressed to you in the previous slide. I told you sporadic cases present bit later by 2 years of age and are usually unilateral and unifocal. The bilateral or multifocal cases usually present yearly and they are familial. And retinoblastoma is usually associated to a change in the chromosome 13 in its long arm. Q is the long arm, and in the Q long arm 1,4 locus. You should not call it 14. You should say it is the 1,4 locus. So chromosome 13, Q arm 14, 1,4 is the place where the genetic mutation occurs. And that genetic mutation, till now we aren't sure what exactly it is, but we follow a nice hypothesis which says actually this gene is a protector gene. It is a protector gene. It is not like that gene is there so the disease happens. It is vice versa. The gene is there, the disease is protected. But somehow, unfortunately, a first hit happens. This is usually because of an inherited state, which mainly happens in 10% of babies. And subsequently, a second hit happens as an acquired mutation, and then the gene gets deactivated. This gene gets deactivated because of these two hits, and the child succumbs to the tumor. This is called Knutson's two-hit hypothesis. But if you see in the 90% of sporadic cases, the first hit and second hit are both acquired, because I told you there is no familial base in sporadic cases. So this is the hypothesis, Knutson's two-hit hypothesis, which tries to explain the changes that happen in the 13q14 chromosome. Okay. A retinoblastoma baby that presents to you usually presents in many stages, like stage 1 quiescent, stage 2 glaucomatous, stage 3 extraocular extension, stage 4 metastasis. Like that, there are 4 stages. commonly the mother brings to you with leukocoria. Leukocoria is a white pupillary reflex. Usually your pupillary reflex, if you see certain photographs of yourself, then you will see the flash creating a pink hue, a reddish hue in your pupil. It's called, it's a normal pupillary reflex. But here you will see a white reflex. If you see a white reflex, usually the mother will notice it when she is feeding the baby. When the mother is feeding the baby, the mother will suddenly notice that white reflex and come and bring the baby to the doctor and tell that the baby is having such and such. This white reflex is called leukocoria. Leuko means white and coria means pupil. So a white pupillary reflex. Next, because that eye is dysfunctional, the eye can squint. The normal functioning eye of the baby will be seeing properly, it will be fixing light. But this eye which is blind will not fix sight and it will go for squint. So this is a case of quiescent stage. Next to the quiescent stage, we have the tumorous stage. In the tumorous stage, two possibilities are there. The tumor can grow into the eyeball. See, the tumor is growing into the eyeball. This is called endophytic. Or the tumor can try to grow outside. This is called exophytic. The tumor is arising from the retina, no? From the retina, whether it grows inwards, it is endophytic. It grows outwards, it is exophytic. So when it grows inwards, it usually develops at a polypoid mass. And this mass will develop calcification in it, and it is called the cottage cheese appearance of the tumor. So if you take a CT or X-ray, you will nicely see the mass, and the mass will have calcification. And you also see a small mass in the other eye. Can you see the calcific mass in the other eye? So this is a case of bilateral retinoblastoma. This CT shows bilateral retinoblastoma. But in the exophytic mass, you will see an exudative detachment. You will see the tumor trying to grow away from the retina and developing an exophytic growth, and this exophytic growth develops a exudative retinal detachment. Next comes the glaucomatous stage. Because there is tumor inside the eye pressure is going to raise. Obvious, no? There is a mass inside the eye. So because of that, the baby develops OPHTHAL mass. The baby develops a big eyeball. Can you see? Can you see a big eyeball which is edematous cornea, red eye, red eye? These things mean OPHTHAL mass. So if the OPHTHAL mass is there, then in a baby, mostly you should rule out retinoblastoma as a cause. Okay, retinoblastoma can be a cause of glaucoma, and then you should not be treating the baby as glaucoma and forgetting that there is a retinoblastoma inside. So that you have to be very aware of. The next stage is extraocular extension. Can you see this stage, the extraocular extension stage? So the tumor just breaks out of the eyeball and tries to go and infiltrate into the orbital tissue, like orbital pad of fat, the extraocular muscles, everything get involved. In this extraocular extension stage, it is very difficult to give tumor clearance. You cannot operate, no? At least when it is inside the eyeball, you can enucleate the eyeball and remove the tumor. At least you can give tumor clearance. But here you cannot even give tumor clearance. So that is the bad thing about this kind of extraocular extension. Worst case scenario is metastasis. Metastasis to the regional lymph nodes, to the preauricular nodes, the submandibular nodes, the submental nodes, then spread via the nerve into the CNS. So via the optic nerve, the tumor spreads into the CNS. So these are the types of presentation of retinoblastoma. So now in the introductory portion on retinoblastoma, we have tried to understand what it is, what is the genetic predilection which produces this tumor, and this tumor usually goes through 4 stages, and those stages now we are aware of. Now in the subsequent PPT, we will see how to investigate it, confirm the tumor, stage the tumor, then take it up for treatment, whether surgical, radiotherapy, chemotherapy. Thank you.